So today we're joined by Dr. Michael Prebeg, who specializes in the treatment of sports injuries and sports performance optimization. Through the identification of dysfunction in soft tissue mechanics, sensory motor integration, perfusion, and articular motion, he has treated athletes and produced unprecedented results in injury recovery and performance optimization. He teaches neuro-functional assessment and Dr. Eloriega's neuro-functional acupuncture techniques to healthcare practitioners all over the world. His private practice currently includes many of the world's top professional athletes and Canada's top executives. Dr. Prebeg is a lecturer and instructor with the McMaster University Contemporary Medical Acupuncture Program. He is currently a consultant chiropractor with the New York Yankees Baseball Club and NHL Players Association. Since 2001, he has covered many world-class events in numerous different sporting activities. His vast clinical experience provides patients and students alike with an extraordinary learning and clinical experience. Dr. Prebeg will get a chance to talk a little bit more about the acupuncture program. We'll stop recording after the end of the Q&A. So after his presentation, we'll have a Q&A, and if everyone can just type in their questions Q&A below, then I will ask him after he's finished his presentation, and then we can have a bit of a discussion. So thanks, Dr. Prebeg.
Thank you for having me. Thank you for doing this. I think it's a great thing for you to do for the profession. Oh, so, okay, I think that's my cue. I'm going to start my screen sharing. Just 2 seconds here. I think that's just 1 second here. Okay, so I was invited here to present a clinical case that I had. I was going to do my clinical case. Actually, we did discuss it, and I do like to do live case presentations in front of groups. This, due to the logistics of Zoom, and now actually, as we were just practicing this and my inexperience with these, electronics these days, I thank goodness we didn't do it, but I do like to do live presentations. So instead of doing a full live presentation, I did do some video footage of a live treatment that shows the results in real time. So we did minor edits just to make it a little smoother, but you will see a live case presentation at the end that will try to put together everything that you're going to be hearing me speak about. So what we're going to do presenting at the end is going to be a patient, a hockey player with anterior hip pinching sensation with associated low back spasms and tightness. Whenever I'm treating a low back, I'm always going to assess and treat the hips. The low back is very complicated. There's a lot of things going on in there. Frankly, the research shows that we don't understand all the mechanisms of low back pain. What we do understand is the lumbopelvic mechanics. Normalizing lumbopelvic mechanics does lead to increased optimization of and adaptability of the mechanics, and therefore the pain is alleviated. And this is going to be explained through the presentation. So then you'll understand a little bit what I'm doing in the video that will follow. So what we're trying to do here is to show you and share with you the power of the neurofunctional model in designing individual acupuncture treatments. I took different acupuncture courses and then early in my career, and then what I did found the McMaster Contemporary Acupuncture Program with Dr. Elorriega. It really did sit well with my scientific background, and it actually answered a lot of questions that I had and made a lot of sense with regards to treating patients with pain with movement disorders. And more importantly, it led to the treating of athletes and then going further on to performance optimization, which is a whole other thing. Um, so, as I said, generally, when you have pain, a patient has to develop adaptive behaviors. When you have, especially an athlete, they are going to have adaptive behaviors to their sport. So in hockey, they'll have adaptive behaviors to their sport, but that still applies to everyone. Say you have an office worker that's going to have adaptive behaviors and adaptive demands on their body due to their activity of whatever it is they do. So these demands are, you can assess and you can evaluate. And then what happens is when you assess and evaluate them, they can become predictive, and then you could also try to restore them. As you know, many people, these adaptive demands also have a threshold and create imbalances. And then once you surpass that threshold, then you have pain. Many people come to your practice, for instance, and say, I didn't, doc, I didn't do anything. I was just reaching over, I twisted slightly, and all of a sudden my back grabbed, and now I'm dying in pain. It's killing me. I don't know what to do. And then now, so what was it that caused that local low back muscle spasm? How did it start? Was it anything specific? Was it them reaching over and grabbing that little weight or coffee cup, or sometimes brushing your teeth? Whatever it is, was that the cause of the low back pain, or was it a failed adaptation to a normal physical movement that happens everyday life? And that's what we're going to explain. Most of the time, these are failed adaptations due to imbalances that are caused through regular daily activity. So we like to take these a little bit further and talk about the neuromuscular function and the neurometabolic function, and then these connective tissue. We assess connective tissue lines of tension. You'll see how we do that stuff. So the more you understand the adaptive demands on the body, the more you're going to understand the the templates, the patterns, pattern recognition that's going to happen with these individuals, or with any individual, with all these athletes. So every sport has a specific pattern of adaptability. Some of those patterns are healthy, some of them are, and even the healthy ones are good to correct in an ideal environment, but aren't not necessary to correct. But then the unhealthy adaptations are the ones that need to correct immediately, because they will lead to an overload of the threshold and then into the pain scenario. So the sooner you could understand these and predict these levels of that adaptability, the better of a clinician you're going to be, the more efficient of a clinician you'll be, and the more predictive outcomes you'll be. It's similar to chess. The more you play chess, the more you can predict the patterns, the pattern recognition of the adaptations, and then the more you can react, the sooner you can react to these different patterns that you're going to identify. So what I have here is a video of a young hockey player. This was a healthy hockey player. This was a hockey player that was playing, had no problems, and we were just doing a preseason physical. And you could see we do a squat test against the wall, and you're supposed to be able to go all the way down. As you can see, he went down about halfway and fell backwards. So then on the right-hand side, you'll see a pictorial there with these colors. So there's nothing specific with these colors. What they are, though, it's an image to show you the different levels of adaptations that specific individual is undergoing. So you got it. See, we just show you tight and tonic, deep restrictions that need to be stretched. You got tight joints, tight muscles, inhibited muscles. That's what the arrows are. So this is just a way to illustrate levels of adaptability. So then you could start to pick up these different patterns. That's all this was just designed to show you. In our patient, it's going to be a hockey player. So with hockey, with any athlete, for instance, with any athlete, it's ideal to understand the sport. You don't have to play the sport. I've treated many athletes from sports that I know, frankly, you know, I don't know much about, but if you listen to the athletes, they will teach you all about their sports. And then if you do a little bit of research, it's all the information is out there. So with hockey players, this is a picture that shows you what muscles are going to be tight and shortened, and shortened and weak, so to speak. We prefer to use the term inhibited. The what muscles are used for rapid acceleration and deceleration, and then you will see what muscles get overused and inhibited and tighter on the posterior side. So other muscles are shortened, other muscles are going to be overused. And there's always going to be a muscle imbalance that is going to be happening that's going to predispose people to injury. Always some kind of muscle imbalance predisposes people to a failed adaptation. So I'm now being a little bit more specific with, let's see if this is a video too, with this individual case. We're looking at movement capabilities. So I watch the person squat, I watch the person lunge, I watch their range of motion. We look at their tensional behavior, the way the different muscles, you'll see the way the body moves and stuff. Then we look at neuromotor behavior, which is going to be traditionally it's called muscle testing, but I mean, neuromotor behavior takes it to the next level because you're thinking about individual nerve roots. So it takes it right up to the spinal segmental level. And you're looking at that, and then you got to understand the biomechanics of the sports. Specific movements such as skating movement. There will always be muscle imbalances that are well tolerated in skating, but that's a different discussion. So what techniques did we use for the treatment of this individual? The first and foremost technique is going to be neurofunctional acupuncture. We're at an acupuncture discussion right here. So, but let me tell you, over my time, 24 years of practice right now, I've got no bias to acupuncture. I'll stop using it tomorrow if you show me a better, more effective technique, especially for me, neurofunctional acupuncture. I'm a clinician first and foremost. I do read the research. I do a newsletter that goes through research, but always has a clinical spin on it. So we'll show that at the end. But as a clinician, acupuncture to this day gives me acupuncture, this system of treatment that we use to this day is by far the most consistent, most significant tool in my toolbox when it comes to treating humans. So that's like a little, just a side note for all of us that are involved in this profession. When describing acupuncture, people ask, what does it do? At its purest level, acupuncture is a peripheral nerve stimulating device that normalizes nervous system activity, increases local blood flow, and improves the biochemical environment. That's just a clean, simple answer. The truth of the matter is acupuncture is much more complex than that. This is another picture. We're not going to get into all of this, but in the contemporary medical acupuncture course, we go over the specific pathways that are effective with every acupuncture needle, from insertion site up the spinal cord to the brain, and from the brain after it's processed and right down to the local segment. Now, and then each one of these processes is going to be stimulated by what we call neuroreactive sites. And that this is a pictorial of what are neuroreactive sites, from Golgi tendon organs to muscle bellies to ligaments to the tendons to the ligaments to the joint capsule, peripheral nerves. These are all vessels. These are all neuroreactive sites that are going to stimulate this phenomenon of the acupuncture cascade that's going to give some kind of metabolic, biochemical, neurobiochemical response to the human body. So this is going to be this is a very complex underlying mechanism of action, but really it's a very simple, clean technique to make those changes. So when it comes to the treatment of the hockey player with low back pain, very common. Every hockey player is going to have low back pain, low back tightness at one point in their life. It is always due to lumbopelvic dysfunction. And then the question is how do you go about treating it? This is an example of one option. I like to show options because there are, what we do like to say, give those blueprints, but there's no, every acupuncture treatment I do, I never do almost the same. I never do the same treatment on one person after 2 days in a row or two treatments in a row. Every one of our treatments every day is going to be different depending on the case presentation that day and the way the athlete or individual will look and come in during their assessment, because it's very complex depending on what's going on with the person. Did they sleep well? There are a multitude of factors, but this is a nice, clean, simple input. This patient happened to have low back pain, but it was due more to the anterior tension of the fascial slings rather than the activation of the posterior. So with him, we had to so-called take off the brakes to allow him to extend more so that he could activate the posterior chain. So we did the anterior primary rami. You could see here the umbilicus is going to be T10. So above the umbilicus is T8, T7, and then below is T11, T12. This is a very common treatment I do for low back pain, especially in the acute, very hypertonic phase, because if you go directly in the posterior side, you can actually aggravate them. They can be in more pain or they can spasm. It's very hard to treat them in that position, in that situation. But you do have to explain to them, why are you treating the front? So by treating the anterior aspect, you will affect the posterior neurological levels. So you have to explain that to the patient so they understand why you're sticking needles in the front when the back is the one that hurts. And then what we did is go down to the femoral nerve. Femoral nerve is going to be, as you all know, L2, 3, and 4. And then that's going to have a direct effect at the spinal segmental levels just below T12. So you can see how from that level you hit all these from T7 to around L4. You will affect all those spinal segmental levels. So this is one input design. And then this is another input design. So this patient was a little less acute, but you can see their primary problem was actually going to be more glute med inactivity and inhibition that failed to support the pelvis, that failed to support the deep stabilizing core. So what we did is we affected from, I just have to move this little thing, I think. Yeah, T12 to L3, spinal segmental levels. L4 and L5 were still a little hypertonic, didn't want to go in there. So what I did, affected L4, L5 by going into the glute med. So L4, you can see on this screen, it will have a direct L4 effect, indirect L4 effect. And then I did connect the L4 to the superior gluteal nerve, the glute med inline technique, which is more fascial. And this is spinal segmental L4. So you'll see it has an effect at a spinal segmental level like this. This is another very clean, nice low back input. So the treatments that are available in my practice, generally, ideally, you're going to have a good assessment, a neurofunctional assessment, and we're going to go over that because a neurofunctional assessment is different than a typical orthopedic assessment, because orthopedics is supposed to rule in or rule out orthopedic conditions. What we're treating is actually, the reality of it all is we're treating neurofunctional problems. If we improve neurofunctional adaptability and tone between agonist and antagonist, pain just goes away. So We use electroacupuncture. I specifically use electricity in my acupuncture because the results are generally better. And the research is starting to, the research does show that adding electricity with the acupuncture, there's a lot of a little bit of a stronger neurohumoral effect. You can use no electricity if you want, but I mean, people that do that tend to use more needles. It's that's a preference, clinical preference. Clinically, I've like this is what I like. Then I coordinate. I use with my electroacupuncture. I use different soft tissue techniques to normalize physiological sliding between the fascial layers. There are people out there that say soft tissue. There's no research to support soft tissue work, but there is tons of empirical evidence, tons of clinical evidence. And then if you even watch Strolling Under the Skin, Google on YouTube, Strolling Under the Skin by Dr. Gilberto, French. I believe he was a dermatologist. He did in vivo camera, and he'll show you the microtubules, how they slide, and the tensegrity matrix that is produced, and the fluid dynamics between each fascial layer, and how they change, and how the microtubules will actually change with their directions and the fluidity. There's ample clinical evidence to support good. The key is good soft tissue work. And then I like to, once we normalize neuromotor mechanics and tensional lines of behavior, then we like to correlate that with corrective exercises. The corrective exercises are going to be much more effective at that point. And then from corrective exercises, you could further in the pro athlete realm, you can go into strength and conditioning and player performance. So that's really my whole spectrum that we work with. So here we have a picture of us doing the electroacupuncture. Here's a picture of the soft tissue work. And right here we have the corrective exercises that are going to be utilized. This is an example of the assessment, again, with the lumbopelvic mechanics. Internal femoral acetabular rotation is one of the biggest predictors of lumbopelvic issues. That's actually been shown in the research as well. And when I say it's, you got to remember here, because the picture looks like I'm turning the foot out, but this is femoral acetabular. The femur is turning internally, the foot goes out. But this is generally average. Ideal is 45 degrees. This was a young guy, so he's already at 45 degrees. This was just an example of an input that we could have used. But after our treatment, you could see here, he improved to approximately 75 degrees. So 45 is the minimum average. If you're older, it could be a little bit less. If you're younger, I've had goalies as far out as 90 degrees out here. They go way out. So just be aware what's normal, a normal measurement for one person isn't what that person is. What's normal and average for a population isn't necessarily relevant to that individual person. So compare both sides, look for symmetry, look for asymmetry, look for the patterns that you see with those people that are involved in that activity. So for hockey, and I see tons of hockey players, I could predict what side they shoot on, what position they play, just by what I'm finding in their assessment. Same with baseball. And I did this back in the days with squash, with tennis, but you have to have a number of players playing the same sport, and then you'll start to pick up these trends. So let's see here. So now here's our case example. This is what I wanted to do live, but because of logistics, it was just, we decided not to risk it. A 30-year-old pro hockey player presents with anterior pain. They say they have a pinching sensation or a tightness in their anterior hip, which is the inguinal region. And then what they'll say is when they with that pinching sensation in their hip, they also get this low back tightness, and they'll point to their low back that comes on and off. This is going to be impinging on their athletic performance and activities of daily living. This is a typical case for any skater that you're going to see. So here we have a video I speak in it, but we're also going to talk a little bit over it just to make sure you guys see what I'm looking for.
It should have 45 degrees of rotation. And you can see this is limited.
And his forward flexion is also
it's
limited.
Limited back. Push up.
And then we muscle test. That should be, I'm not that strong. That guy should be way stronger than me. Look at those legs.
It's good.
That's his adductors are good.
Turn sideways, face that way.
Now we're going to be testing his abductors, primarily glute med.
Relax, relax.
So I put him in a specific position. So this is first the extension. And you guys can see here, this is tight. He should be a nice arc like this, a nice C.
Ready? Push up from my head.
And again, I'm not that strong.
Hold up.
I shouldn't be able to do this.
Good. And you could lie on your stomach.
Now that was glute med. Now this is going to be glute max.
Hold. And 1, 2, 3.
And I'm not that strong.
Hold 1, 2, 3.
And that's his glute max. So now we're going into the treatment. I chose, you're going to see in the next image, I chose to go to his obturator nerve first. Obturator nerve has a direct innervation to the femoroacetabular joint. In this scenario, I decided that if I can improve the hip mechanics of this pelvis, that will have a direct correlation to his low back pain. So what we did is we did an obturator nerve stimulus, and there's something that I go through here. One, that's the 75 centimeter needle, 75 millimeter needle. So we go through neuromotor stimulation of the obturator nerve. But remember, the anterior branch, the adductor longus, is innervated by the anterior branch of the obturator nerve, which gives a direct innervation into the femoroacetabular joint. We'll show you a picture of that. And then, remember when I flexed his knee up? I didn't like the way it was flexed up. Watch this too. That was the adductor longus. That was for the hip joint. And now we're going to go after adductor magnus. You got the problem with this technique is it's not the problem really. It's actually the beauty of it all. The better you understand your anatomy, the more precise, the more accurate, the more choice of. Oopsie, went a little strong there. That didn't hurt. This doesn't hurt, by the way. It sometimes, if people aren't used to it, it gets them off guard, but it does not hurt. It should feel good. So here is adductor magnus. So this, you can see the posterior part of his adductors was jumping. Now we checked his flexions better, and look at his internal rotation, already improved.
Let's see. Much more rotation. Do muscle test, pull up.
And that's better.
Turn facing that way.
Obturator nerve. What are the nerve roots? L2, 3, and 4. Same as femoral. Uh-oh.
This is still an issue.
This still sucks.
Up here.
And then here,
push up.
Adductor, that's the abductors.
You're good, relax.
So now we're going to attack this a little bit more directly.
Greater trochanter, ASIS, traditional GB29, but deep.
So one of the things with people with big muscles, you need big needles. Not necessarily thick, but longer. So I know this area is safe, and I will bury that needle right to the acetabulum, and you can see the beautiful internal rotation that we have from hitting. That is going to be glute medius and glute minimus. And that's a beautiful neuromotor stimulation of glute medius and glute minimus, which directly insert to the joint capsule.
This is still.
Still, I'm not happy with this hip extension. Remember how we assess and reassess, and this helps me with his pattern recognition. So did you notice already though, his abduction was much stronger.
No, it's good.
And that's a beautiful femoral nerve stimulation, like the first picture that we saw. We found the femoral nerve, we insert the needle near the nerve. And I'm using this technique. One is treatment, one is assessment, because this is showing his specific patterns. Look at the rotation he's got.
Good.
So you can see we went through a step-by-step problem using acupuncture as treatment and as assessment to help with understanding this patient's specific pattern recognition. And then from here, I could add in, oops.
45 degrees of rotation.
Sorry. Let me see the next step. There we go. So these are the levels of innervation. So one of the things here that you guys saw me address was the obturator nerve, and you could see the direct innervation of the femoroacetabular joint capsule. This is very important. A lot of times in sports, but specifically in hockey, patients will come in feeling a pinching sensation with flexion, leg flexion, and they'll say that you have FAI or it's your psoas. I've heard that, which I don't understand that because you're flexing. The psoas is actually being taken out of the movement, but that's what people say. FAI, we can't diagnose. We could say impingement, but we can't say FAI because that's actually a radiographic diagnosis. So, but we neuromodulate, we stimulate this nerve. We can improve that in many times just by a simple acupuncture obturator nerve intervention. So these are different, again, different targets, neurofunctional targets to affect lumbopelvic issues, which will lead to low back problems. And you could see all the spinal segmental levels that we are looking at and thinking about. So that is the neurofunctional model in a nutshell. What I did here is this is the QR code for this is, remember I talked about the I have a newsletter that we talk a lot about clinical studies, but correlate them to clinical application. I'm a clinician. I'm not a researcher. But I love clinical practice. I observe my patients. I see the results, and that's where I get most of my information from. But like I said, you still do have to keep up to date with the clinical research, the scientific research. And then, so that's why I created this newsletter, and in Pit Lane, which I like to, talk about, because that goes into the performance part of the athletes, which is a passion of mine. But that's a different story. But now we're open to some questions with regards to what you might have with the neurofunctional model.
Thanks, Dr. Prebeg. It's interesting. How long have you, I guess you've developed this technique over the 25 years that you've been practicing or so. And you presented this case as a very specific, I guess, example of how your technique can really work in your practice. How long have you been specifically doing this technique, or does it always change a little bit?
What do you mean that? Well, with the technique itself, really, I learned in 2000 when I took the contemporary medical acupuncture program, which was the third acupuncture program that I took, and that was the one that the other two didn't really, like I said, jive with me, more or less. And I took this McMaster program with very little hope, and it really, within the first day, answered a lot of my questions, filled in a lot of the clinical gaps that I clinical kind of I guess I could say gaps that I got from school, and then opened up my eyes. Like, sometimes we don't know everything that's going on with the human body, but doesn't mean we can't treat it. Like, we're always learning more and more about the human body, and the more people think that we know all about the human body, the more issues there are, because it's a very complex phenomenon, and we have to be clinicians through and through and continue to learn and evolve. Um, I've been practicing like this since I got out of school because I was spoon fed this. So I fell into this, and this is what I love, and this is what I've been doing. But I definitely have more fun today than I did um, in the past, just because you get better, you get more precise. But the results, I'll tell you, and that's what I said in the middle of the presentation. Acupuncture, like I'll stop using it tomorrow. I've got no people, people come into me and they say, I don't believe in acupuncture. Well, I don't believe in it either. But you show me something that gives me better results, and I'll start doing it. Um, and so clinically, like it's phenomenal. And I've been doing this for, I guess, similar to this, but a little bit more precision, a little more accuracy. That's continually evolving. Like, for instance, when I hit the obturator nerve, I hit the obturator nerve, hit adductor to differentiate the anterior branch of the obturator nerve and then the posterior branch of the obturator nerve. That's a skill that kind of evolves. Does that answer your question?
Yes, yeah. So we have some questions coming in. One of them, they were asking, what are your indications for using low frequency and high frequency when you're
That's
doing the NFA?
that's a good question. As a general rule, low frequency is probably what you resort to. Mid frequency will be a little bit more aggressive in a specific tissue level. So if you have really hypertonic, chronic, post surgical scar tissue, something you're physically trying to break up, you could use a mid frequency like 8 to 10 hertz. I know they didn't ask about that, but then people will be sore. So you don't want to use it as first time. Low frequency is very well tolerated. It's got the super segmental effect. It's going to be very, very good. High frequency is going to be more of a segmental effect, the 120 to 180 hertz, and it's going to give you more immediate pain relief, but not long-term metabolic changes. So that's going to be used more for sclerotomal pain, more for sensitized nerves. That's really what I use the high frequency on. So if I could really delineate a sensitized nerve, I could, we do a technique called short circuit, long circuit, blank the nerve. We use high frequency. It fatigues the nerve, so it's not hypersensitized. It just really makes it, decreases its hypersensitivity. It can still depolarize, so it's not that you make them numb, but you don't make them feel the sensation of pain as easily. So that's when we use high frequency. Low frequency is what you always resort to. High frequency would be more sclerotomal or neuro irritated nerve pain.
Do you ever use anything higher than that 180, like 500?
No, my stims go up to my stims are the ES 1107. I think what are they? I don't find clinically. I haven't found. Yeah, they go up to 500. I haven't found a difference between one. I just put it on high. Frankly, clinically, I haven't noticed a big difference between 150 to 500. And the research was 120. The 80 to 120. That's what they said in when we're in the research. But I mean, clinically, I haven't noticed a difference. I've played with it. I've thrown it up to 5. Patients, it doesn't feel much different. I mostly go with patient sensation, how they feel, because the patients have to be comfortable. That's another thing with our acupuncture techniques. Even though you see muscles jumping and things moving, it has to be comfortable. So if the patient is uncomfortable at any level, you can see me always fiddling with the intensity to make sure that it's well tolerated. I don't like to have patients feeling the sensation of pain, because then you're going to be stimulating a different neural pathway.
So I know there's some questions about the courses and what's part of the courses, which we will get to after this Q&A. But one of them is, what length of needles are you using on the stomach?
40s, generally 40s. In certain situations, you could use a little bit more,
Right.
some a little bit less. Um, but that's a good question. People always say, how deep you go, and my answer is, I'm going to target tissue.
Right.
Where is the target tissue? And that's where I'm going. If the person has like there's guys that have quads, like quadzellas, that you use a 40 and you're barely getting through the dermis. Like you're not getting anything. You need a 10 centimeter like a what's it called, 10 centimeter needle to get down, and you're burying it. I've buried the 100 centimeter needle in quads to get down to the femur, the glutes. You have to same thing. You have to. What's your target tissue? So with that patient that we saw, I actually used a 10 centimeter needle, one of the 100 millimeter, and it was buried right to the acetabulum. I know there's nothing there that I could hit. So the first thing is safety too. I know where I can hit the bone. There's nothing there that's bad. I'll bury the needle and I'll stimulate those deep fibers. So part of the results are getting those really deep fibers that are very, very hard to hit with any other technique. And that's where I come back to acupuncture having such a strong effect with all sorts of patients, but specifically with athletes. The athletes are really starting, going towards this.
And what would make you determine whether you would treat the anterior versus the posterior side first?
Well, that was simple. So that's assessment. One is if it's super acute. Number two is if they're fascial. Remember, I did the sideline. See, I showed you guys a lot more than you realize. When I did the sideline test, if he is very tight in the anterior plane, I don't care what you do, you cannot affect the posterior plane. So you first have to release the brakes. So with the car, if you're at a stoplight and you're holding the brakes and you slam on the gas, the tires will spin, but you ain't going anywhere. So until you release the brakes, nothing's going to happen. So that's why I was you have to normalize lines of tension. And that's what we talked about. So if the anterior sling is very tight, posterior chain can't be stimulated. So it's not, so that's the reason why. And number two is if they're super acute and the posterior is very sensitive, I found that treating it first, sometimes you increase the spasm. There's too much risk. I prefer to minimize my risk of aggravation and maximize my therapeutic benefits. Sometimes I'm thinking, shouldn't I? The front has never steered me wrong.
Great. Do you have a good source that you can recommend to review anatomy with respect to which spot on the nerve can be stimulated?
They're the motor points. We've dissected many of the nerves. There is one, you know what? There's a trigger point, like, no. The simple answer is no, but the other answer is yes. The information is out there. Is there one good source? No. Alejandro found some books. There's these trigger point injection books that were actually very good. So we correlated that with a lot of the acupuncture insertion sites. Um, and then we have specifically dissected countless cadavers, and you could see the normally where the trigger points are. There are these neuromotor. The nerve comes in and branches out like a little spider into the muscle, and that's the neuromotor point, the neuromotor junction that you can stimulate the best. The more precisely you hit those, the more effective your treatment's going to be. So there's trigger. The answer to that question, I think, is there's trigger point injection books. The that's a bad answer. I'm sorry. There's no good answer to that question. Yeah, sorry, but there is no clean
Right.
cut neuromotor book out there yet that I know of.
Um, would muscle inhibition eventually come back after a while?
Yes, yes and no. So people will say, how long will this treatment last? And the answer to that is possibly very long. How long are you not going to go back to your activities? Well, and how long are you going to keep doing have perfect posture and perfect movement patterns? Well, I'm going to go back. I'm going to go back and play hockey tomorrow. well, then this is going to come back probably after tomorrow, like, or soon after that. So how long are you not going to go sit in a chair for 8 hours sitting there over a computer looking like this and not move? If you sit like that's not the way the body was designed. The body's designed. If you go out for a walk and you're doing deep squats and you're moving around in a large variances of motion, these things will last. The treatment will last longer. If you start to do movement patterns that are unnatural for the human body or overuse uh, types of movement patterns that create maladaptations or adaptations that the body has to get used to, then the treatments will have their limit for sure, and you're going to have to go back and get them again. So, how long will the treatment last? I get that very commonly in clinic, and it goes depends on the stress you put on your body to revert all this stuff. Because the treatments have the possibility of lasting very long once you normalize things.
Sure, yeah. Can this style of neurofunctional acupuncture improve reaction time, coordination, or proprioception in hockey players?
Um, No. So yes and no. It could optimize movement behavior and movement patterns. It can't make the person has to practice a lot of the other stuff. So, for instance, a lot of in hockey players specifically, sometimes my coach is trying to get me. They call this thing called edging, where they open up their skates and my hips are locked up. I can't. And the coach is saying, you got to open up your hips. You got to open up, and they can't because, as you can see, when I internally externally rotated him, he was tight. All of a sudden, you treat them. They go, Mike, my edging was so much better. So at that level, if you optimize movement patterns, you'll have a performance effect and they'll feel smoother, more efficient, um, to make them have better coordination or better reaction. There's a bit of a stretch there, so I don't want to make empty promises, but they will be able to train harder and train more consistently. So that stuff will create more effective or larger results with regards to their reaction time and their strength and their speed and their agility. So if they're moving more efficiently, allowing them to train more efficiently, that will allow them to play a little bit more efficiently. But that's the paradigm. That's the whole spectrum. So it's not as simple as one equals 1 plus 1 equals 2. It's 1 plus 1 plus 2. You know what I mean? It's a multiple of things to equal that final um, outcome.
And how does it impact the nervous system regulation, such as optimizing the parasympathetic response post game?
Yeah, so I did a lot of that. There, so post game, people come in and they're very high in their sympathetic tone. Acupuncture, I will have an effect at helping reset their sympathetic parasympathetic nervous system. So it does, but those are going to be very. There was tons of times I was doing auricular acupuncture, different what we call systemic regulatory points, the very strong autonomic points, LI4, liver 3. It has a very strong effect on helping normalize parasympathetic activity, post competition.
And can this style of treatment help people with injuries sustained from MVAs?
Yeah, 100%. Why not? That's what I was explaining all the time. Of course, all the same principles apply. And then, Frank, like, so you do the same assessment, look for lines of tension, try to restore, normalize lines of tension, look at the neuromotor activity, get them exercise. This will help get them exercising, and then that'll help strengthen them. Even I've seen catastrophic type injuries that, you know, people thought couldn't be helped, but all of a sudden we can stimulate. For instance, we've got a patient that was crushed by a car. The femur was crushed, and the surgery, uh, restored saved the femur, but the soft tissue, was a mess, and she had a very hard time activating her quads. Her hamstrings actually had decent activation at the beginning, but her quads weren't firing. So we did a lot of femoral nerve stimulation peripherally as well as spinal segmentally, all 2, 3, and 4. And then next thing you know, she starts exercising and getting some femoral nerve activation, quad activation. And then next thing you know, she gets stronger. And now all of a sudden, you have someone who had zero quad activation to having to have zero femoral nerve activation. You got to be careful. If it's a true nerve, you know, if a cut nerve or stuff like that, we've tried. So you have to do, you can do a nerve conduction study, but there are, depends on how early in the stage of the injury it was. But this patient, we did get normalized neuromotor activity and then help them strengthen. They're still working on things, but they're compared to where they started, they're night and day. So again, this is where you have to work with the team. If the nerve, another patient that was hit by a tractor trailer, and he's a paraplegic, but he saved his quads, but his hamstrings, his glutes, those don't fire. But you know what's holding him is actually the obturator nerve branches that affected the adductor magnus. So this person is going to walk, and it's not pretty, but he's managing to make do. So again, there are like if these are functional issues that can be restored, acupuncture can help. If it's a lesion or something, there are limitations.
So, what about post-concussion symptom management? Is that along this lines?
So every concussion does have a whiplash associated disorder with it. I've had many discussions with doctors, MDs, other practitioners regarding this. I've treated many complex concussions and stuff like that. Back in the days, we used to say rest. Now we try to get them a little bit more active. Again, it's a similar thing to a muscle. What we can't treat the brain. What we can treat is the neck, the TMJ. You start working with it, they feel a little bit better, start getting a little more blood flow, and start the healing process through that. So, can it possibly help? Not the brain part. You can try to stimulate blood flow to the different parts of the brain through acupuncture, through the peripheral nervous system, like the greater occipital nerve innervates the posterior meninges. That's going to directly involve blood flow to the cerebellum. But so you can possibly help that stuff just through blood flow. But the reality is acupuncture could help treat the whiplash associated disorder that's involved with the concussion, which will have I wouldn't say direct, but indirect effect to help to help the patient along the concussion-like symptoms.
Thank you for all of that information. I think we have covered all of the questions. Oh, we have one more. So timing of treatments. What's the ideal time of treatments? For example, pre-game, post-game, off-season, in-season?
Yeah, they're all different. I've done them all. A pre-game treatment's going to be very different than a post-game treatment or an off-season treatment. Depends on what you have available. So let me just turn this thing on. Sorry. So pre-game, you got to make sure that you don't overstimulate their nervous system and fatigue them. So you have to be very, very careful. But you can stimulate and improve fluidity so that the athlete feels smoother, more efficient on the ice. But you can also make them feel flat. So you got to be careful. And every athlete's different too when it comes to that. There's some guys in baseball that the stuff I do to them, I could never do to a hockey. The hockey players would kill me because they'd feel like they're skating in slush. But these two individuals are very different humans. So again, you have to understand your patient, and that's a little bit of a learning process. You kind of get to, but you pick it up quickly together, and that's why it's always a joint venture with the practitioner and the patient. And the better you know your patient, the more that you can do. So Pre-game, you have to be careful. Not you can treat them, but it's going to be a different treatment. Than post-game is going to be more parasympathetic regulation, trying to help them recover. And then an off day with 2-3 days in between is going to be a very different type of treatment because you can make them flat because they have 2 days to recover. So sometimes you make them flat for the next day, but then they have a bounce back and their whole nervous system recovers and they feel amazing 3 days, 2-3 days after. So that's where I tell you there's all sorts of different levels.
Right. It's really kind of knowing your athlete and what they need.
Yes.
Is it always necessary to stimulate the nerve peripherally and at the corresponding nerve root levels? Is it more just situational depending how the test and retest goes?
Yeah, it's directed according to the test. So the test and retest, and then I'm already when I'm doing that, I'm predicting a pattern because I've seen these patterns. So I'm already kind of, but you won't know them right away. But if you do the assessment process continually every day, you start seeing these things come pretty quickly. Um, but I'm already predicting what this person's pattern is, and that's how I develop a very specific treatment protocol for him. So if he muscle, so for instance, if he muscle tested very strong, that individual did test strong in the adductors, but I was doing that more for the passive range of motion. So neuromotor activity was good, but functional tensional behavior was not ideal, and that's what I was trying to affect more than the neuromotor.
All right.